Good day to everyone. I am going to discuss the pathology of kidney masses among pediatric patients. This is part 1, and I am Dr. Christian Dominic Rosales. Here are fast facts when dealing with pediatric renal neoplasm. Renal cancers are rare in a pediatric population and include a spectrum of pathologies that may challenge the clinician in selecting optimal therapy. Proper recognition of the lesion may be difficult, and the appropriate surgical procedure is paramount for lesions suspected to be malignant. Pediatric renal neoplasms are notorious for their variant histologic patterns, many of which overlap with those of other pediatric renal neoplasms. Majority of the tumors, however, have at least focal areas with classic histology. Correct identification of this group of diseases depend on the knowledge of both classic and variant histology along with adequate sampling. Renal cancers are unusual in children, accounting for nearly 6 to 7% of all childhood tumors. They are often detected by a parent bathing or holding the child during routine physical examination, in the clinics, or screening of children with known clinical syndromes, with predispositions to renal disease, or incidentally during investigations for other intra-abdominal processes. The key challenge here is distinguishing malignant neoplasms from benign masses. I'm going to start my discussion with nephroblastoma, also known as Wilms tumor. Nephroblastoma is one of the most common solid tumors of children, and over 90% of cases happening before the age of 6. Rare examples have been reported in adults too. The tumor is more common in children of African descent than of the other races, and is slightly more common in girls than boys. This is associated with several hereditary disorders, such as the WAGR syndrome or the Wilms-Aniridia genitourinary anomaly mental retardation, Beckwith-Wiedemann syndrome, hemihypertrophy Eddie-Dennis-Drash syndrome, which comprises the Wilms tumor, intersexual disorders, and glomerulopathy. WT1 mutations are present in only 10% of sporadic cases, whereas WT2 abnormalities are much more frequent. There is slightly a higher predilection among women or girls, and patients usually present with abdominal mass. The most common sites of metastasis are the regional lymph nodes, the pulmonary organ, and the liver. Prognosis is also dependent on the tumor stage and the architecture of the tumor, with patients having low stage 1 and 2 tumors with favorable histology having an excellent outcome. Here's a table showing the staging of Wilms tumor and other pediatric neoplasms. A tumor is assigned stage 1 if it is confined to the kidney and involvement of the renal sinus is confined to the hilus allowed. Stage 2 is when the tumor extends beyond the kidney, including the perinephric fat, the renal sinus beyond the hilus, and renal vein, but the surgical margin status are negative. Stage 3 is assigned when residual tumor in the abdomen following resection including positive margins, presence of peritoneal implants, spillage of tumor during surgery, involvement of the regional lymph node, and the tumor is removed non-contiguously. Stage 4 is given when there is presence of hematogenous metastasis, including those of the intra-abdominal organs. And lastly, stage 5 when there is bilateral renal tumors. Nephroblastoma classically display a triphasic pattern with admixtures of blastema, stroma, and the epithelium. The blastema, which is the undifferentiated component, consists of cells that are small and round or polygonal with a hyperchromatic nuclei and a minimal cytoplasm. In the diffuse pattern, the cells are poorly cohesive and tend to invade or infiltrate widely, often beyond the renal capsule. Here is a low power magnification of nephroblastoma, showing to you the three components of the tumor. Once again, the tumor is derived from nephrogenic blastema and is composed of varying proportions of the blastemal, epithelial, and stromal elements. So the B stands for blastema, the E for the epithelial component, and S for the stromal tissue. Nephroblastomas have a pushing border surrounded by a fibrous pseudocapsule. One exception, however, is the diffuse blastemal type, which infiltrates adjacent renal parenchyma. The spindle cells resemble immature mesenchyme with a myxoid or a fibromyxoid pattern. The most frequent differentiated component is the skeletal muscle. However, any type of stroma can be observed, including cartilage, fat, osseous tissue, and even neuroglial tissue. The epithelial component can range from difficult to recognize primitive tubules to well-developed tubular or papillary structures. Of greatest importance histologically is assessing for the presence of nuclear anaplasia. Anaplasia is properly defined by the presence of the following details: nuclear enlargement to at least thrice the size of adjacent nuclei of the same cell type, presence of multipolar polyploidy mitotic figures, and the presence of diffuse anaplasia or focal anaplasia in extrarenal tumor defines a significantly worse prognosis. The arrow points to you the evidence of anaplasia in the said tumor. In here, we can see multipolar mitotic figures as shown on the left arrow, and tumor cells that are at least 3 times larger and more hyperchromatic, as shown in the right-sided arrow. That's all for part 1. Kindly proceed to part 2. Till then, thank you for watching.